Hello, we are a non-profit group, Mothers for Mental Health Care Reform. We promote treatment with dignity. Today we bring you an educational piece about current medical practice from Dr. James Kennedy. Dr. Kennedy is a professor in the Department of Psychiatry at the University of Toronto. Dr. Kennedy is an advisor to the Schizophrenia International Research Society. Also, we have with us a PhD student, Ms. Kosar Teymouri. Kosar is completing her PhD on schizophrenia and neurobiology. Welcome. We are so glad to have your thoughts today from both of you.
Thank you, Leslie, for that kind introduction. My clinical practice is in schizophrenia, but I'm also trained areas like Alzheimer's disease and dementia and neurology. That's also areas where this main topic that we're interested in today called anosognosia. I pronounce that slowly and carefully because it's a mouthful. So anosognosia can occur the classic example is in stroke patients, particularly the ones that have a stroke that damages the right side of the brain, but it affects the left side of the body. And in up to half those cases, they have a true unawareness that the left side of their body is paralyzed. And you can tell them 100 times that they're unable to use their left hand, and they just can't comprehend what the person is saying to them. That's sort of the most severe and anatomically concrete, or, we know the location that's damaged because we can see the stroke damage very clearly in a MRI scan of the brain. But that's not the only region of the brain that's involved, and we can get into those details later. Basically, it's better described as a circuit. So the stroke breaks part of this circuit in the brain that allows the person to be aware of what they're doing and what they're not doing, where they are in space and their position and all of their faculties. Basically, it's one can say it is kind of a failure of self-monitoring. This word anosognosia. And so it arose in the field of neurology with stroke patients. However, it's become a very useful concept, or it describes quite nicely somewhat more complex and subtle change in patients who don't have any observable brain changes in the best MRI scans and different types of brain imaging that we can use in disorders like schizophrenia and bipolar disorder.
As one of the Mothers for Mental Health Care Reform, I've been intrigued by this whole concept of a lack of insight. Do you find that people confuse that with denial? What about you, Kosar?
So I don't think Dr. Kennedy would know about this better, but I don't think it would be denial. It would be just lack of insight. And it's just very important outcome predictor. And it's mainly associated with the treatment, how they're adhered to the treatment, and with their symptom remissions, relapse frequency, and risk of violence and harm to themselves and to others. So I don't think it's just denial of being sick only. It's just they're absolutely unaware of what harm and impact it has on their behavior, has on themselves or the others.
That's so interesting.
Yes,
Dr. Kennedy, you were starting to say that there are certain parts of the brain highly correlated with the lack of insight. Maybe you could describe it in terms for a layperson how are scientists trying to isolate particular deficits in the brain? You mentioned MRI?
Yes, and this now we're switching to what's called functional MRI imaging. So it's like taking a video of the brain, not a picture. So a standard MRI scan is a picture, and it's kind of three-dimensional, which is great, but it's a one snapshot. Functional MRI observes over actually milliseconds, seconds, minutes, up to 10 minutes or longer of what parts of the brain are lighting up as the patient is just resting and then doing a variety of tasks that they are able to do while they're kind of locked into this big donut of the MRI camera. And that there can be these questions or tasks that probe them as to what they're aware of. And, a simple question that could be asked to them is while they're sitting in the scanner or lying in the scanner, is that, do you feel that you have any problems with taking your medication? And the patient will, let's say they say no, but in fact, all the clinicians and family members are very clear that they always say that they don't need medication. They don't have a problem that requires the medication. Patient keeps saying that, but they very much have problems with judgment, memory, awareness of how other people are feeling and thinking. And those functions, as the patient, considers that concept of needing medication or not, the frontal part of the brain, and this is now mostly in schizophrenia and bipolar disorder, the front part of the brain, which looks fine with the picture, but when you see kind of this functional video, the front part of the brain, we're talking about the frontal cortex now, it is under functioning when the patient is given these probes to inquire as to how much they need medication, or so that introduces a second sight. We already talked about the right-hand side of the brain, but that's very much connected with the front of the brain. And the front of the brain is very much involved in more subtle, much less observable than the paralyzed patient who is unaware that their left hand doesn't work. In this case, we believe that based on the evidence that the frontal lobe is the main failure in this circuit, this set of sites in the brain that together create this complex awareness of how their condition and behavior is being perceived by others around them.
It's fascinating deficit in the brain. We also saw the Mothers for Mental Health Care Reform were reading a paper put out by Dr. Gary Remington, Julia Kim, and Philip Gerritstein that talks about cortical thinning, but I guess is that throughout the whole part of the brain, or is that one
Yes.
area?
Yes.
Prefrontal cortex as well. Sorry, I interrupted.
Just to explain what cortex means, it's like the entire surface of the brain. And that's what can be measured quite accurately by these single photographs of the brain. They can measure with these very accurate techniques how thick this advanced part of the brain is or is not. And so then that is tells another part of the story. When you think of this anosognosia can occur in Alzheimer's disease, patients deny, to use that word we talked about, and they deny that they have memory problems, and they're much more likely to have that symptom of Alzheimer's disease if their cortex is thinner. They just have less capacity to process this complex set of inputs that allows the person to be aware of what they're doing. Basically, this is in terms of behavior in this case.
Interesting. With the deficit in the physical organ, we can understand that, like you were mentioning earlier, no amount of talking is going to convince that person. Does that mean that talk therapy won't help at all with anosognosia?
No, that not necessarily. It generally could be seen as a cause of this problem. However, going back to patients with, say, smaller strokes that don't cause paralysis, but they cause weakness in parts of the body, you can use cognitive therapy to help those smaller stroke patients and schizophrenia and bipolar patients to train themselves to have increasing awareness, to teach them to pay more attention to how they're being perceived by others. And what happens in the brain is that other parts of the brain can take over that function if the person is working at it. So if the big if here is, if the patient can sit and pay attention during cognitive behavior therapy, then there's a lot of hope that they can coax these other circuits to take over that function.
And what about medication? Can that rectify anosognosia in our schizophrenia patients?
The best answer is not very well. If what the medication, the antipsychotic medication, is good for is quieting down a kind of noisy cortex where there's all the cortex is getting all these inputs from the ears, the eyes. Part of that problem can be this sort of active, noisy activity in the brain, and the antipsychotic medication quiets that down. But that doesn't necessarily, it might help. It should help somewhat the insight that the patient would have, because it allows this more sensitive circuit to function without all this noisy interference that the frontal cortex and the side of the brain, they can't integrate everything when there's this, disorganized, noisy part of the cortex that's causing these psychotic symptoms like hearing voices that don't exist, and that kind of scramble up the importance of, how your mother feels about how you're behaving. The psychosis can mix that up and distort it so that the patient is not aware how distraught the mother is. For example, they're talking about all these different things in one sentence that doesn't make sense. So antipsychotic medication can quiet down that noisy disorganization. and it does a pretty good job of that. And antipsychotics, their standard mechanism for the last 50 years is to, in particular, block the dopamine activity in the brain, which is one key part of keeping the brain in balance. It's thought in psychosis that there's parts of the brain, but not all the brain, are unable, they don't have enough dopamine function to maintain attention and this awareness.
That's very helpful because, we know that with medicine, our relatives do function much better. But then we read statistics that 50 to 80% of patients who do have schizophrenia, they don't understand their own mental disorder. And it's hard for us to appreciate that it's not obvious to the person. Can either of you comment on that? Or those statistics make sense? 50 to 80% of people who have schizophrenia have anosognosia?
Yes, well, I think Kosar has a good example from the Galvin family that supports those statistics. Kosar, what was the rate of lack of insight or anosognosia in the 6 members of the Galvin family that had schizophrenia?
5 out of 6, actually. So they had 10 sons and 2 daughters who were the youngest of the 12 siblings, and Lindsay is the youngest daughter. And Don Jr. was the first son of the family, who was very handsome, very smart. He was a pre-med student. All of a sudden, he starts having bizarre behaviors, and then in few years, 1 or 2 years, he's diagnosed with schizophrenia, and he manages to get married. However, his wife wanted to leave him. What I wanted to say is this isn't a great example of lack of insight. He loved Jean so much, but he was absolutely unaware of the trauma that his behavior caused to Jean.
Kosar, of the impairment, the terrible impairment that lack of insight has on loved ones.
Yes, there's the 3 other brothers. There was Matthew and Joe. Matthew is actually and actually Joe. They had repeated hospitalizations, and they are good examples of having lack of insight for their illness and not adhering to medication. They would refuse treatment, and at some point there was a part in the story that Matthew stopped taking clozapine because of the adverse effects it had on his adverse side effects it had on him, and he had to repeatedly go to the hospital, but he didn't know why he's there, and he was home. He just said, "I'm homeless, but there's nothing wrong with me." He was not homeless, however. So I think these 2 are great examples of, as Dr. Kennedy mentioned, the impact that it can have on the loved ones, but it doesn't mean that they don't love them. But again, the impacts that have, it's not because of the denial, it's just that they cannot put themselves in other person's shoe to see what they're doing is causing them.
That's so interesting, Kosar. And it's a puzzle to me that schizophrenia is in every culture, in every country, and quite often, I know for my relatives, they do not have a family of their own. So it's really a puzzle that it could have a genetic link. But you are aware of how many different genes are playing a role in this illness?
Yes. So Dr. Kennedy would know this better than me, but however, there is no one gene that causes schizophrenia. It's extremely polygenic. And the most recent finding was that there was more than 280 parts of our gene that are associated with having schizophrenia. So how they do it is they look at this schizophrenia patients, and they look at their genes and they compare it with healthy people. And this is a lot of data. So 40,000 schizophrenia patients and 70,000, for example, healthy controls. And that's how they saw that there's around 287 locations on the gene that are associated with schizophrenia. However, which makes it even more complex to just pin down what is the mechanism that's causing all of these disturbances.
Wow, so close to 300 locations on all different spots. So it's really not directly caused by a particular genetic flaw.
No, and also environment has a great impact too. And again, it's very obvious with the experiences of the Galvin family. Finally, they knew what is causing this for this family. It was one genetic mutation, but another brother had that genetic mutation, but he decided to go to the farms and he never was diagnosed with schizophrenia. And I think that was a great example of how he separated himself from all the stress that was maybe, I'm not saying causing, but making the other brothers show the symptoms and develop the schizophrenia. They were all predisposed, but he didn't develop it. It might be the environmental factor.
It's just amazing to us that there's such a volume of research on schizophrenia. And we had a question about why would some doctors really, they don't acknowledge anosognosia? Like we know under the law, a patient may be capable for particular decisions and may be incapable about their psychotic treatment decisions. But several times we've seen a psychiatrist discharge a person who does have anosognosia, even though the family sees dangerous signs, and we may believe that they are incapable. We have a mother with lived experience who's also joining the conversation today. You were asking about a situation where your son was psychotic and presented very well?
Yeah, so my son presented really well to the doctor, and he had, he was telling the doctor he was going on a trip to Thailand, and he had a one-way ticket, and he also showed all his medications that he was taking. So I had said to the doctor, how could he have extra medication? He's not taking it. And because he appeared so well, and, at that time, the doctor at that time said he could go on, that there's nothing he could do. He couldn't hospitalize him because he was capable at that time. And
so our question is like, how do these doctors not acknowledge this? I don't know, Dr. Kennedy Kosar, can you help us understand this?
Just one thing I want to add is that you can, from what I understand from being in this several times that this has happened, that you're deemed capable in some areas and incapable in others. Is that correct, Dr. Kennedy?
Yes, that it can definitely be correct. For example, the person may be very incapable of managing their finances. They just, are unaware or can't understand, or so they have, a substitute decision maker for their finances. But in other realms, in their family life, social interactions, they're have reasonable function, and therefore they're allowed to make decisions about their care and how they move through the world, and they hopefully they have insight to the fact that they're not able to hold down a demanding job, but they may have insight that they do have this memory and organization of thoughts problem, that prevents them from, being a manager, let's say, whereas they realize that they can be a good like security guard or do filing or deliver the mail at these simpler jobs. And that's a nice example of being aware, having insight as to what station you can have in society. And they end up being very they making a contribution, but only if they have insight that they can't tackle more complex tasks. So it's a person by person individual decision on the part of the patient, the family, and often a court judge if the patient gets admitted to the emergency room and deemed at that time incapable and may be a potential harm to themselves or others, then the doctor in that moment in the emergency room declares them incompetent to make decisions. But here in Canada, the province of Ontario, they are seen by a judge, sort of a neutral, well-informed person, and the case is made to allow the patient the freedom to make their own decisions or not allowed to make their own decisions. And so that judgment is done by a small group of well-trained people.
Mm-hmm. But when they're in the emergency room, are they just using mental status exam, or are they using aid to capacity evaluation? Are they using the Montreal cognitive assessment? As Mothers for Mental Health Care Reform, we would really like to see a bit more of a standard screening rather than just an informal conversation to determine whether or not they have any insight and what is really causing the psychosis. Can you help us there?
Yes, it would be great to have this assessment of capacity, like have a tool, a structured tool that's used by a good number of emergency rooms, and with time it can be evaluated as to what it can do and what it can't do. But in my opinion, it can only help. Why it's not being used is just this simple busyness of emergency rooms, and there's time constraints, and there's two other patients screaming in the waiting room, shouting obscenities, and it's more chaotic. And so the doctor has to make fast decisions in the emergency room. But maybe we can develop the capacity that a nurse practitioner or some other personnel who's experienced in talking to and evaluating psychotic patients to do this assessment of capacity examination, and it's only a good thing in my opinion, but the problem is it takes time, and it's the basic purpose for an emergency room is to keep patients alive and safe, and beyond that they don't have a lot of time to get into more details. But usually that patient gets transferred within, well, if everything's working, 10 or 12 hours to an inpatient ward. And that's a much better location where this assessment of capacity could be done by a nurse or a social worker or, someone trained to evaluate patients. And
exactly. Yeah, because there's no shortage of tools used that are available, but we don't see them actually being used when we look at the clinical notes of our loved ones. And it might be for those reasons that you mentioned, that there's a transfer from the academic to actually the pressures of the ER. And we would love to have thorough assessment similar to what people are eligible for with dementia. You know, if we could have the occupational therapist or someone do a thorough report, that kind of an assessment would clarify. And even if it shows that, you know, maybe this person is not quite severe, it does explain to the family, you know, here's the score out of whatever number, and here's the score that, you know, would be the threshold, and here's the score that would be for your particular relative. It would help us understand, because the mothers get so frustrated not understanding what's going on. You were starting to say something, Jay?
Yeah, so my question is, if it's not being done in the emergency, is any of the testing being done in the inpatient setting? Because some of our family members have been there for sometimes 6 weeks, 2 months, 3 months. And still a lot of family members are coming out being quite psychotic, delusional, and having auditory hallucinations and having at the same time anosognosia. So I'm just wondering.
Yeah, it's not commonly used in the inpatient wards. It's not used on a regular basis. And here at the Center for Addiction and Mental Health, and you know, we're the largest mental health facility in Canada. We do more than the average, you know, community hospital, in the sense that we have the brief psychiatric rating scale, BPRS. That's done on every patient on at least a weekly basis. And that's a great measurement of how well or not well they're responding to their medication. We also have a schedule for assessment of negative symptoms. The negative symptoms meaning how withdrawn the patient is. It's called negative because they're unable to produce the right behaviors. So they're socially withdrawn. They have no motivation. They don't want to talk to anybody. And that needs measurement, because that's really impairing when they get out of the hospital and they just, you know, stay in their bedroom or wherever and just don't interact. And that's a real problem. So that's an important scale to do, and we do that. It's like this lack of awareness and lack of insight. The medications that we use are not very helpful to the absence of healthy behavior, like so social withdrawal and you know, no interest in talking to other people around them in order to figure out how to get through their activities of daily living and so on. So those are very difficult symptoms to treat with the medications that we have. As I mentioned earlier, they are good for quieting down these noisy brain activities that disorganize the patient and cause hallucinations and cause them to be unable to put together a sentence that makes sense.
Exactly. And we were discussing amongst the family members that there are all these patterns of fixed beliefs, jumping to conclusions, and so on. But it seems that a person cannot give consent if they're not capable. So capacity really has to come first, looking at lack of insight, looking at anosognosia to determine whether this person is able to give consent. Just because they might be agreeable doesn't mean that it's really consent. And it's quite confusing for us as family members, because We see very detailed guidelines on how to make sure you're being clear about consent, but we don't see that first step of the capacity evaluation. And like I say, we do see it in academic literature, but the mothers are saying, no, it's not really happening in the ward.
Yeah, I mean, things need to change, but the changes mostly involve doing more structured measurements of the patient, which require more time by well-trained clinicians or staff, and the inpatient wards are very busy, and there's always management problems. But when I started to think of what kind of action items we all could think about, I want to harken back to the use of behavior therapy and talking therapy. You know, that can be helpful. And of course, it takes a lot of time. And it's got to be done several times a week. So maybe we can train, a mid-level clinical staff, personal support workers, and the groups of people who we would have in bigger numbers to put in the time to sit with the patient and keep working with them in a trained way to practice being aware and practice trying to perceive how they don't have the capacity to decide some things. And those are very difficult symptoms to treat. The medication doesn't help very much. So that's the only successful route to help these people, and it costs a lot of time. So how do we fix that? How do we organize? How do we get the patients talking to someone who's educated enough to help them practice trying to recognize how they're failing and not being aware of it?
Mm-hmm. And I'm looking to the future where, if it were possible, that all patients appreciate their need to have appropriate antipsychotic medicine or treatment. There'd be so many fewer trips in ambulances, trips to the ER, fewer apprehensions, less time in legal courts, less burden on our society all around. I would think that many relapses would be avoided if we could get a solution to anosognosia. That's got to save entire society money. So I see the point, yes.
I just have one quick question. Does neuromodulation therapies help with anosognosia?
Yeah, so in other words, you're talking about brain stimulation with different magnetic or electrical methods. It really, there's not much research yet on that. The most common neuromodulation is transcranial magnetic stimulation, or TMS, and it hasn't shown any kind of notable or remarkable helpfulness for lack of insight and these symptoms of denial that the patient needs medication. It can provide general help to the brain, and if it may help somewhat with the negative symptoms. We haven't proven that yet, but and if the patient has a component of depression, it certainly has been shown to help that. And of course, depression can make the person withdrawn and not interested in talking to people. This, lack of interest and motivation. So neuromodulation or brain stimulation can help some of the time with some of those symptoms, but it's not a clear, we couldn't recommend it for all patients with lack of insight or anosognosia. But maybe with more research, we'll be able to do more precision medicine. That is, identify the patients who would benefit from neuromodulation for these symptoms.
The only reason I just suggested that is I was at a conference in the US, and they're looking at perhaps this is maybe the future, and looking into more neuromodulation and cognitive testing for the future.
Yeah, it's a promising area, but it needs more research.
Well, thank you so much for your time today, Dr. Kennedy and Kosar.
My pleasure.
And we can hope that future research might focus on this very important barrier to health treatment. Thank you.